Let's get started with our session today. Noor is saying your voice looks like you're sick. Well, no, it's not sick, but I have a lot of sick people at home, so I hope I'm not getting sick. I hope that you are. I hope that you are not correct, but I'm fine. But I'm just a little bit tired because today Sunday, Noor, Sunday I give 2 lectures in a row in the morning. So, and I tried to have a session today with you guys so that we don't like stop for 2 successive days. That's my target always. So we'll start where we left over. We left over at the adenoid cystic carcinoma last time, right? So we left over at the adenoid cystic carcinoma. So as a quick preview, I mentioned in the previous session that we have an approach for the salivary gland tumors. Whether you see oncocytic or you see oncocytes, that's the first type, or that's the first pattern that you will see. And the other, or the second pattern, is basaloid, which is blue cells, and that's what we started and we didn't finish in the previous lecture. So there we go. Let's start where we left last time. Okay. All right, so we're starting with the adenoid cystic carcinoma. The adenoid cystic carcinoma, as you see, it's adenoid. Adenoid make you remember that this has like tubules. It has this, it's usually having this tubular architecture. See these cells lining a lumen? That's what adenoid reminds me of. So adenoid make me remember these adeno-like tubules, or tubules, which is full of secretions or full of material. As you will see, I will talk about this material later, but this is how I remember adenoid. And cystic make you remember even more that you have some kind of content inside these tubules or inside these lumens. But actually this tumor is basaloid. As you see, a lot of blue cells, but there are 2 cell types here. There is the myoepithelial cells and the duct cell. The duct cells are those which have small nucleus and compact dark blue nucleus. That's what you see here. And the duct cells are the cells which have slightly larger nucleus. See that? The ones that have slightly larger nucleus and some kind of vesicular chromatin with some prominent nucleoli. Like this is a duct cell. This is a duct cell. That's a duct cell. This is a duct cell. But these like compact, small blue nuclei with just dark chromatin, and you don't see any prominent nucleoli, that's myoepithelial cells. So actually the tumor is composed of 2 types of cells. And actually this tumor has 2 grades, low grade, high grade, which depend on how many, which cell constitute the predominant cell in the tumor. Like in the low grade, it's myoepithelial cells, which is predominant. That's why you say low myo. Low myo. So it's low grade myoepithelial cells. So myoepithelial cells is the predominant in the low grade, and the ductal cell is predominant in high grade. However, in the boards and in the board questions, they won't ask you whether this is a low grade or a high grade, honestly. It will just need that you hit the diagnosis of adenoid cystic carcinoma. They will ask you about the molecular mutation or something of this kind. They would never, ever ask you whether this is low grade or high grade adenoid cystic carcinoma. It's a carcinoma, cribriform, tubular, or solid. However, the most common pattern is the tubular form or the tubular pattern, as you see here in this picture. The myoepithelial cells, as you see here, the myoepithelial cells form kind of pseudocysts. So actually, these are not true tubules. These are not like true glands. This is not glands. This is not tubules. These are actually pseudocysts. These pseudocysts have some collections of a kind of glycosaminoglycan compound, which is GAG compound. You know, these GAG compounds that we used to take in biochemistry, the chondroitin sulfate and heparan sulfate and these kind of things. So that's an accumulation of some glycosaminoglycans. And on the other side, you might have some accumulation of red basement membrane-like material, as you see here. So see, it's either blue GAG or pink basement membrane material. Whatsoever you are having pseudocysts, these are not true secretory tubules, or these are not true secretory acini. But I'm telling you how I remember adenoid cystic. So adenoid, because it has this tubular gland-like lumens surrounded by cells. Cystic, because it has these pseudocysts filled with GAGs or basement membrane-like material. Two cell types, myoepithelial cell type and ductal cell type. And the grading depend on how much or which cell is predominant, low myo, high ductal cell. And here we go. This is the second tumor which show PNI, perineural invasion, with pain and paralysis. Since it occur in the parotid gland, it usually happen in the parotid gland. So it usually extend to the facial nerve and the kind of trigeminal nerve. And it sometimes lead to some local pain in the face due to the perineural invasion. We had a previous tumor showing PNI as well, or perineural invasion. If someone can remember it, or even try to try to open the book or try to open the notes and tell me which other tumor we mentioned that it shows PNI or perineural invasion. Yes?
Polymorphous carcinoma.
Polymorphous carcinoma, good job. So remember, the polymorphous carcinoma had the same thing. And remember the P's of polymorphous, palate, PNI, and these kind of things. But polymorphous is not commonly to make you feel pain in your face, because polymorphous actually doesn't happen in the parotid. The most common site is in the most common site of polymorphous carcinoma is in the
palate.
Yeah, exactly.
Palate, yeah.
Yeah. So if it's in the palate, so you would barely have any facial pain, because it would never infiltrate any branch of the trigeminal or any of the facial nerve or these kind of things. This is PNI. It shows PNI with pain and paralysis due to involvement of the facial nerve. It has a persistent local spread. However, it's saying that it has a good 5-year survival, but poor long-term survival. Like the 10-year survival is bad, but 5-year survival is relatively good. That's the second basaloid carcinoma, and that's it. So we have two important entities in the basaloid carcinoma, or in the basaloid pattern, which are the acinar cell carcinoma and the adenoid cystic carcinoma. You know what? And the others like polymorphous basal cell adenoma, polymorphous carcinoma, canalicular carcinoma. You know what? I lost all my annotations in the previous one. And the credit goes to Adam, my little boy. He disconnected the power from the from the wall. He just disconnected the power, so I lost power and I lost all my annotations. However, it's fine. I will redo the annotations and repost the notes for everyone. So now the next one in the line is the spindle cell pattern, or the spindle cells. Spindle cells is very important, and you have only one entity here, which is a very famous one, and it's very highly likely that you will get this on your board exam or in the Q banks, which is pleomorphic adenoma. Of course, why? Because this is the most common tumor in general of the salivary gland. But if you're asking what is the most common malignant tumor of the salivary gland, does anybody know? What's the most common malignant tumor of the salivary gland? Here it is. Here it is, mucoepidermoid. The one that we didn't take, it's mucoepidermoid carcinoma. That's the most common malignant salivary gland tumor. However, the most common tumor in general is, or the most common mass in the salivary glands is pleomorphic adenoma. And luckily, that's benign. They call it pleomorphic because it's architecturally pleomorphic. Like it might come in any pattern. However, the common histological features that you will see in all the patterns is having three components. It's a triphasic tumor. This reminds me of Wilms tumor. We have some tumors with this triphasic or like three components, this kind of thing. So it's a triphasic tumor. Number one, you will see ducts. Okay, so there is ductular structures. Number two, you will see myoepithelial cells here. They form some small islands in a sea of mucus or in a sea of a myxoid stroma. So sea number three is the sea of mesenchymal tissue, which is usually myxoid stroma. However, in this myxoid stroma, you might see any of the mesenchymal components like cartilage, bone, anything you might see as a mesenchymal. Most commonly, it's cartilage. They sometimes, or adipose tissue. Sometimes you see some adipose tissue floating in this mesenchymal-like tissue, aside from having the myxoid stroma. See, mesenchymal-like tissue, ductular structures, myoepithelial cells, and they are usually admixed with the stroma, as I told you, like forming some islands inside the stroma. And then you have the mesenchymal-like tissue, which is usually a sea of myxoid stroma, but it can be chondroid, osteoid, adipose tissue, anything, okay? This is very important fact. I don't know why they love it. They love it. They love that this tumor has tyrosine crystals sometimes. Like you might find some crystals in the tumor, which are actually tyrosine crystals. And this is the molecular cytogenetic fusion, which is pleomorphic adenoma. See, PLA, pleomorphic adenoma. We call pleomorphic adenoma PLAG 1. Pleomorphic adenoma PLAG 1. So PLA in PLAG 1 reminds you of pleomorphic adenoma for some reason. It's usually PLAG 1 HMGA2 fusion. That's the very common, or that's the most common fusion in the pleomorphic adenoma. I forgot to say the most common cytogenetic abnormality in the adenoid cystic. In the adenoid cystic, you have the MYB. The MYB. And there is another type, which is MYBL1. So I just study MYB, and that's it. MYB, MYBL1, anything, but just MYB. It's the adenoid cystic carcinoma, MYB. PLAG is easy to remember because it's pleomorphic adenoma. So PLAG 1, pleomorphic adenoma, that's very easy to memorize. And that's the triphasic tumor, benign tumor. They usually grow, forming a huge size. Of course, this is how it looks in cytology. And I will show you this in the cytology review, in which we'll go over a lot of pictures. But this had the classic troll hair. Troll hair, it's because of the myxoid background and myxoid stroma. So the myxoid stroma is usually in the background, making like a red hair of a troll. That's troll hair. That's the pattern on cytology. But you will see that. And you will see the spindle cells here. And of course, the roundish cells, which are, I believe, either the myoepithelial cells or the ductal cells. So the ductal cells or myoepithelial cells are these ones, and the spindle cells are these ones, and that's the background myxoid stroma, which is the troll hair. That's on cytology. I don't need you to know any other spindle cell tumor except for the pleomorphic adenoma. That's the only one we need to memorize. Then moving on to squamoid or squamous. Please note that squamous metaplasia of the salivary glands might look very, very, very deceptive. Because when you see this, what you might think of? Anybody can jump in? Anybody can jump in and tell me what can you think when you see this pattern?
Maybe we can think of squamous cell carcinoma.
Yeah, you might think of that these are squamous cells forming some islands, and the background look very suspicious. So I might suspect that this might be a squamous cell carcinoma, but actually you can see this pattern in normal salivary glands. That's called necrotizing cyalometaplasia, squamous metaplasia. Usually they give you the case scenario of a patient who've been long suffering from inflammation of his salivary glands. Like, for example, he had stones in his salivary glands, or he has long history of pain and inflammation of his salivary glands. So they tell you that there is a kind of chronic inflammation involving the salivary gland, and they will give you this picture. So you see some islands of squamous cells. Well, okay, that's squamous metaplasia, and that's necrotizing cyalometaplasia. That's because of chronic inflammation. However, moving on to this, the first entity in the squamoid. Yes, Noor saying SCC. Yeah, squamous cell carcinoma. It's the mucoepidermoid. That's a very self-explanatory carcinoma. I always, I love it actually. That's the most common malignant salivary gland tumor, and it happens highly likely in the parotid gland, and it's a mucoepidermoid with an M, and it shows MAML2 gene fusion, which is mammal2 fusion, M and M for the mucoepidermoid carcinoma. And the name of the tumor kind of dictate the histology, because you see mucu, this means that you are having mucinous cells. Epidermoid, which has cells that are epidermal-like cells, which are the epithelial cell component. That's the epithelial cell component, which look like epidermis, epidermoid. And then you have some kind of cells which are intermediate cells, which doesn't look really mucinous, doesn't look really epidermoid, or doesn't look really squamous. Because see, like this cell, for example, this one, it has the nuclear features of the squamous cells, but it has clear cytoplasm and mucinous cytoplasm like the mucinous cells. Like, see, it has like the clear cytoplasm which look like this, but the nucleus look like this. So that's why they call it intermediate cells. So that's why we say that mucoepidermoid carcinoma, you remember muco for mucinous cells, epidermoid for squamous cells, and then there is some kind of intermediate cells in between, and that's what you see. Actually, the mucinous cells are actually filled with mucin, and you can stain this mucin with PAS or musicarmine, and it has this MAM for M, mucoepidermoid, M, mammal2 gene fusion. You must grade this tumor to see how aggressive it is, whether it's low grade or high grade, but this is in your clinical practice. It's not in the boards. In the boards, they won't ask you whether this tumor is low grade or high grade, because to know whether this tumor is low grade and high grade, you need to have a full slide and you look at different areas, see how much cystic the tumor is, how much solid the tumor is, whether the tumor is totally well circumscribed or does it infiltrate everywhere? Does it have more mucinous cells or more squamous cells? Does it have, how many mitoses it have, or it has? Is there low mitotic count or high mitotic count with necrosis? That's are the points, or these are the points that you differentiate between low grade and high grade based.
Sorry, I have a question. Like, what's the cutoff for mitotic count? Like, what's low and what's high?
Low mitotic count, high mitotic count, that's usually, I believe, 5 to 10 per 10 high power fields. I don't really remember exactly the number, but if someone can look this up real quick and let us know, that's important in case you are having a slide or you're having a case and you're assessing the tumor. But board-wise, this table is not important, but I was asked in this table in one of the tumor boards. Like the surgeon, the head and neck surgeon, we signed out the case as high grade mucoepidermoid, and then he said, so what's the meaning of high grade? So I told him this table. I told him, well, it depends. So we assess a lot of things. We assess whether the tumor is cystic versus solid, whether the predominant cells is the mucinous or the squamous. The more it's solid and the more it's squamous, and the more mitosis, more necrosis, the less, and the more infiltrative is the high grade one. So that's how we differentiate. So if someone can tell us if there is any exact cutoff number, sometimes, you know, they leave it very open, because maybe the WHO doesn't specify. Yes, Mariam, looks like she has something to say.
Yeah, there are different criteria. One of them is MSK grading system. That in MSK, 0 to 1 is low grade, 2 to 3 is intermediate, and more than equal 4 is high grade. This one is based
okay,
on
that's a mitosis, right?
Yes, yeah, for
that's
mitosis.
That's per 10 high power field or per what?
Yes, yeah, per 10 high
Okay.
power.
Okay.
Yes.
And the so that's like there is different grading systems, and that's why maybe Dr. Schaberg in his notes, he just gave up writing down a number. He's just telling you the outline, you know, the broad rules. Maybe that's the cause. All right, so that's mucoepidermoid. So now we remember mucoepidermoid. Okay, squamous cell carcinoma. Oh, no. Just make sure that you are not dealing with squamous metaplasia. Make sure that it is truly squamous cell carcinoma. And if it is truly squamous cell carcinoma, please exclude metastasis, because you rarely have a salivary gland tumor which is entirely squamous or entirely squamous cell carcinoma. It's usually metastatic from somewhere, like it depends from the oral cavity, from the pharynx, you never know, but that's usually metastatic. Finally, we have the high grade. You have one, a pure SCC in a parotid. Such a heavy head and neck service you have in your program. Okay. Salivary duct carcinoma, I would say honestly that out of these high grade tumors, I didn't see in the Q banks for the boards, except this entity, carcinoma X pleomorphic adenoma. That's the only entity I saw in the Q banks. I never had a chance of having salivary duct carcinoma. But I will tell you the thing. The thing is, what's carcinoma X pleomorphic adenoma? Carcinoma X pleomorphic adenoma means someone who had a long history of pleomorphic adenoma, and he had this mass for a very, very long time, and he's usually old age, by the way. And then he had a transformation of the tumor to a malignant form, or pleomorphic carcinoma, which they call it carcinoma X pleomorphic adenoma. The thing is, the most common element, see, like, let's go back to the pleomorphic adenoma. The most common element which produce carcinoma in the pleomorphic adenoma is the ductular or the duct structures. So the most common cancer which arise on top of pleomorphic adenoma is salivary duct carcinoma. And that's why they would never give you a question with a pure salivary duct carcinoma pattern, Because why should I give you this when I can test you for this pattern on top of a pleomorphic adenoma one, and then I will ask about the molecular, and I will ask a lot of other interesting stuff. And I will also make sure that you identify the salivary duct carcinoma pattern. You know, you got it? So that's how it is, I believe. So carcinoma X pleomorphic adenoma, as I told you, that's carcinoma arising on top of pleomorphic adenoma. And most often it's arising from the ductular elements. So it's most often salivary duct carcinoma. And the cytogenetics here is very important because you still have the BLAG1 HMGA mutation, which is BLAG1 PLA, pleomorphic adenoma. That's the benign type. And then the malignant transformation arises due to de novo TP53 mutation. So that's a tumor with TP53 mutation. If that's a tumor with TP53 mutation, this means that you will have a very pleomorphic tumor with necrosis and a lot of mitosis and destructive growth, and it can't stay in its place for one extra day. It has to be removed right away. Usually the patient has a long history of a mass and is usually an old age with rapid, severe enlargement of the mass, lots of mitosis, necrosis, destructive growth, pleomorphism. As I told you, that makes sense with the TP53 mutation that we have. So how to identify the salivary duct carcinoma? It's like breast duct carcinoma, actually. Actually, it looks like breast duct carcinoma. See, you have pleomorphic cells filling the duct lumen, but there's still some kind of microlumens there, but the cells are nearly taking over the whole duct lumen. See that one? And they're starting to go out in the stroma and infiltrate everywhere. And sometimes you might have the comedonecrosis, like the DCIS, like the duct carcinoma in situ of the breast. You might have it in the middle of these ducts, which are filled with the malignant duct epithelium. So malignant duct epithelium filling the duct with central necrosis, that's comedonecrosis, and infiltrating the surrounding, that's the salivary duct carcinoma, which, as I mentioned, might arise in the transformation of pleomorphic adenoma, which is carcinoma X pleomorphic adenoma. BLAG1, TP53, remember that. Well, clear cell. Oh, okay. There is a clear cell carcinoma of the salivary glands as well. Interestingly, we don't have we don't have the classic stains here. Anybody remember what are the classic stains for the clear cell carcinoma that we used to have everywhere? Not CNI. There are some other.
Napsin.
F1 beta.
And napsin.
Napsin. Yeah, Muhammad, napsin, and Abdurrahman said HNF1 beta. So HNF1 beta and napsin A, you remember you take a nap in order to be clear. So that's napsin A and HNF1. However, you don't have these classic stains here. However, you have an important fusion for some reason in the clear cell salivary gland carcinoma, which is EWSR ATF1. EWSR, I believe, is there in Ewing sarcoma, right? If I'm not mistaken. EWSR is there also in Ewing sarcoma. Okay, that's EWSR ATF1 like EWSR like Ewing sarcoma. However, that's in the clear cell carcinoma of the salivary gland. You have the classic, of course, polygonal clear cells with clear cytoplasm and some intervening hyaline sclerotic stroma that's in the intervening area in between the clear cell. Clear cells are full of glycogen, and you can stain this glycogen with PAS as well. So that's the same like the other classic clear cell carcinomas that we saw elsewhere. Epithelial myoepithelial carcinoma, well, just read. Just read. So these are the entities that we have for the salivary gland tumors. I will go over the different patterns so that we make like another storm review on the salivary gland tumors. Just remember that we had the oncocytic pattern, which has the oncocytes. In case you see solid nests of oncocytes, that's what? That's oncocytoma. Watch for pleomorphism and mitosis. It becomes oncocytic carcinoma, and it usually comes as oncocytoma. That's the first one. Then, if you have the lymphoid tissue, the mature lymphoid tissue surrounded by the double layer of oncocytes, that's what? That's Warthin tumor, okay? Warthin tumor. Then, if you have the oncocytes with some kind of very clear granular cytoplasm, and the key word is having these eosinophilic secretions in the lumen. Remember this? Eosinophilic secretions and granular vacuolated cytoplasm, oncocytes, red cells. That's secretory carcinoma. And then we went over the basaloid. We had the basaloid of blue cells, basaloid, that's basal cell adenoma or monomorphic adenoma. And the key in monomorphic adenoma or basal cell adenoma is having this basement membrane-like material in the periphery. There we go. And you have blue cells forming some tubules. And then basement membrane-like red material in the surrounding. The basement membrane-like material or hyaline basement membrane-like material, which is there like wires here, is the key that you can use to differentiate this one from the adenoid cystic, because sometimes with these secretions or with these like red things in the lumen, you might think, that's like the secretions in the lumen, so that's adenoid cystic, but the answer is no, because you see this wire basement membrane-like material in the periphery. That's pleomorphic, that's monomorphic adenoma, basal cell adenoma versus basal cell carcinoma. Then we have polymorphous carcinoma, in which we have just some tubules lined by some blue cells, very widely separated from each other. Palette, P63 and P40, PNI and PRKD fusion. Remember, the P is for the pleomorphic carcinoma. And then the canalicular carcinoma, you have these canals, which look like water canals, which you draw on a map. So they are like anastomosing water canals or anastomosing canals of blue cells, cords and ribbons interconnecting. And it usually exclusively comes from the upper lip. Then the acinar cell carcinoma is the key word is the zymogen granules. These blue granules in the cytoplasm, the zymogen granules, and the acinar cells, dog1, SOX10, remember this. Then the adenoid cystic, you have the adenoid, which are tubules, cystic, pseudocysts. These pseudocysts is either filled with gags or filled with hyaline pink basement membrane-like material. Remember the MYB, and PNI is the second tumor with PNI. Then the pleomorphic adenoma, in the spindle cell component, you have the triad of the ducts and the islands of myoepithelial cells and the myxoid stroma with mesenchymal elements. You might see some chondroid elements. You might see adipose tissue. You might see anything. Squamous, remember the mucoepidermoid, mucoepidermoid, intermediate cells, MAM, mucoepidermoid, MAML2, which is MAML2 gene fusion. And then in the high grade, we have the carcinoma X pleomorphic adenoma. Remember, it has the black one from the pleomorphic adenoma with a de novo TP53 mutation, which make it aggressive, and have a malignant component, which is usually salivary ductal carcinoma. Thumbs up for the common and the clear cell carcinoma finally. Well, that's the classic polygonal clear cells with some background hyaline stroma, and it has the glycogen PAS positive filled cytoplasm. Thumbs up for the salivary gland tumors, or the common salivary gland tumors that you need to know. For the last part of this notes, I would say that this is not for your boards. And I didn't feel it's helpful even in practice, honestly. He's trying to build up a differential based on the architecture, like which tumors are encapsulated, which tumors are circumscribed, which tumors are infiltrative, like B biphasic, C cytology. He's trying to give you different approaches. And then he has like a big tables collecting the IHC. Sometimes it's useful to refer to these tables while you are practicing or having a case. However, not in the board Q banks, I believe. This one I will always say, like, print and hang somewhere you visit frequently. I won't say where, but you might choose whatever, like somewhere you visit frequently and stay for a while. So print this and hang it there and just keep looking at it many times. Like adenoid cystic carcinoma, it's MYB, clear cell carcinoma, AWSR. But the key things is adenoid cystic, of course, the clear cell, the mucoepidermoid, the pleomorphic adenoma, of course, the black one, the polymorphous PRKD, the secretory ETV and TRK, and the acinic cell NR4A, and the carcinoma X pleomorphic adenoma is BLAG1 and TP53. He didn't write it down here, however, you need to know it. Also basal cell adenoma / basal cell carcinoma, it's CTNNB and cyclin D mutations. This table helps you a lot with repeated hitting this table many times with your eyes. You have another table in the soft tissue tumors or the bone tumors. That's also a gold. So there are 3 tables that you need to hang where you visit many times. It's the molecular for the salivary gland, the molecular mutations for the bone, and the molecular mutation for the soft tissue. That's it. These are the 3 papers that you need to hang. And maybe like one time you take turns. Like one time you hit this table, one time you hit that table, and the last time you hit this table, and you keep going over and over again until you memorize these by heart. Because these are very, very important, very boardable for your board exam. So you can't miss this question. This Milan system and the grading of the salivary gland tumor. Oh, it looks like you guys all like agree on where we are going to hang these tables. All right, so I can't tell from the chat. So it's that's fine. All right. So the Milan system, they usually use this in cytology. However, I never seen a cytology question of a salivary gland tumor asking me which category I would put this tumor in, or this mass in, like whether it's non-diagnostic, non-neoplastic, atypical of undetermined significance, neoplasm benign, neoplasm uncertain malignant potential, suspicious for malignancy, malignant, these like cytology grades and the percentage of each one having the risk of malignancy, which one is like 90% malignant is the frank malignant, like suspicious of malignancy means 60% malignant. However, I believe if you are entering a cytology board, like the cytology boards, or you are doing a cytology fellowship, you might need this table, I believe. I believe you definitely need this table to categorize any salivary gland mass. I believe they use this in all the institutes for the sign out for the salivary gland masses, right? They use it in your institute, right? Yes, of course. Yeah, definitely. That's how it goes. Also in the thyroid, they have like kind of similar table Is also suspicious for malignancy, atypical, these things. However, these things you won't have it in the boards. They will ask you in the boards whether this is a colloid nodule, that's like papillary thyroid cancer, or this is like a medullary thyroid cancer. Is giving you this plasmacytoid features, or like these salt and pepper. And also the same thing in the cytology for the salivary glands, you will see they will give you like a picture of pleomorphic adenoma and ask you what's this. You say pleomorphic adenoma, or what's the mutation in this. You select BLAG1. Or they will give you like a picture of mucinous cells and epithelial cells here and there. So you would say like, yeah, this is mucoepidermoid carcinoma. So I will show you all these in the cytology magazine that we will go over. There should be a lot of pictures. Boom, 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 picture diagnosis. That's how I will go over cytology. A lot of pictures. I might get you like, I might get another picture for the same entity that I covered before. Like I will give you like a mucoepidermoid again, and then go back to it. So we will keep going back and forth until we get used on how each thing look on cytology. So you get familiar with as much things as possible. Okay. All right, we're done with the salivary gland tumors. Now we have only one thing left over in the head and neck, which is the other selected head and neck topic, which I will collect in one presentation. So I will take your permission of giving me until after tomorrow so that I work on this presentation tomorrow, because I never made this presentation before. So I will make this presentation from scratch. Like I have some things with already prepared presentation. Like I have a presentation for the bone for the boards. I have a prepared presentation. I have neuropath for the boards. I have one presentation which cover everything. There are some things that I prepared already presentations for, but others I did not. So that's one of the presentations that I will prepare from the beginning or from scratch. So I will take your permission of giving me until after tomorrow so that we go over it. So let's now go over some virtual slides. Okay. Hold on just a moment. Okay. Salivary glands. Skin, bone, GI. Head and neck. Okay. All right, head and neck. You got it. Where is it? Sorry, it's taking a little time, but we'll get there. That's a lot. Oh my God. They have a lot of entities in head and neck here, this book. Okay, here it is. So we have okay. So there you go. First slide. It's a strange question who will go first, but you know. Abdurrahman.
I'm here.
Oh yeah, that's strange, right? Very strange.
It's strange because we don't see anything.
Yeah, I will let you see right now. So there we go. We have a female in the 6th decade, so in the 60s, with a painless, unifocal, slow growing mass in the parotid gland. Okay, let me show
Okay.
you the slide. Let me show you the slide. Okay. We're going
Okay.
back. So let's look. Here is, of course, the low power. Here is the mass, as you see.
Yeah.
Here is the mass, okay? And we go high power and look. Here is how it looks like on high power. So which pattern you see here? Is it oncocytic, basaloid, spindle? What do you think?
Well, I kinda have a spot diagnosis in my mind. I'm not sure if it's right or not, but it reminds me of secretory.
It reminds you of the secretory.
Yeah,
Why you said secretory?
because of the secretions inside this.
Where?
Those,
These
yeah.
in the lumen, but the secretions looked like circles. It had like should I go back to the notes?
No, it's fine. It's fine.
Let me show you. Let me show you. That's how secretory carcinoma looks like. So it's very red. The cells are very red. They have granular cytoplasm, and they have these see globules of secretions in the lumen. Okay.
I see.
So that's a wrong hit. So any other anything like any other thing, like do you find any other hit in mind? See that area?
Yeah. I don't know if this is a basaloid, but I don't know. It's so pink.
Basaloid, yeah, we are there. We're almost there. So that's basaloid. But what do you think? What kind of basaloid? So the cells are arranged in what? Do you think that these cells are having like tubules?
Yeah, kind of nests and tubules.
Yeah, so kind of tubules with some kind of crowded cells in the surrounding, and then there is this thing on the periphery of the cells, and it's sometimes
Is it the
there
monomorphic?
between. Yes, that's the monomorphic.
Basal cell adenoma?
That's basal cell adenoma. See, here is the diagnosis. Basal cell adenoma. Can you see that on the side? And then the key microscopic features, you see these basaloid cells. Okay, here is basaloid cells. And then saying basophilic nuclei. Yes, I agree. And some central cells with abundant cytoplasm. Well, okay. And there is these duct-like structures in some areas, which is tubules, as we mentioned. And she didn't even mention about this basement membrane-like material. However, we saw it in some areas, right?
Yeah, that's true, but it's not as prominent as the one in carcinomas.
We saw it in some areas. That's a basal cell adenoma. Okay, so basal cell adenoma, do you remember the molecular? Does it have any molecular signature?
Is it the NTRK?
NTRK.
Oh, ATP6. No, that's secretory again. Okay.
It's the secretory.
I don't know what's wrong with secretory in my mind now.
Basal cell adenoma does not, but pleomorphic adenoma does. So if it's monomorphic adenoma, it doesn't have any molecular. But when it becomes pleomorphic adenoma, which has a lot of components, it shows black one, right?
So it was a tricky
sometimes
question.
it has also sometimes the I think it has
CTN BB1
CTN and cyclin D. sometimes, but not always, not all the time. It shows cyclin D1 and beta catenin, or the catenin CTTN. But rarely, you know, but the most likely is the black one in the pleomorphic adenoma. Okay, so let's move on to the second one, Dina. Okay, so Dina, the second one.
Yes, I'm ready.
Okay, ready. All right, I love this. I'm ready. Okay. Let's see. Well, okay. So here we go. Okay, let's go over this one. I will tell you the history right now. That's a female in her 5th decade. That's it, with a mass. Salivary gland tumor. They didn't even specify the site. Okay, so let's get started. Let me share the screen.
Okay, from low power, it looks like the thing in the center, this is the mass, maybe.
Yeah, this is the mass, and that's the background normal salivary gland.
Normal salivary gland.
These are the acini. And there we go,
It's
high power.
well circumscribed.
Yes, that's well circumscribed. I agree. It's not even infiltrating.
And kind of patchy. There are areas that look cellular, other areas looks kind of myxoidish, maybe.
Yeah,
like this here.
This one has some like kind of myxoidish area. Yeah, I agree.
And spindle cells in between.
Some spindle cells, but let's
look
at these areas.
Here they look like they're forming big cystic spaces, and the cells, I want to say these are like the ductal cells.
Well, yeah.
So here's the thing. So
yeah,
this looks like what Abdurrahman was talking about, the pink, the secretory type, the one with the pink small like secretion.
I always say, I know virtual slides is very, very tough. But, that's why it has a different skill than looking at pictures, because in pictures they give you a picture of the spot diagnosis where you need to look. So the thing is, based on my narrow experience in dealing with virtual slides, I would say don't jump to a diagnosis very fast.
Okay.
Look at different areas, look carefully, and for like at least 1 minute, you start looking around and start seeing collecting the keywords while you are looking. And then at the end, reach the highly likely diagnosis, because there is always a lot of overlapping features. Like right here, you saw spindle cell. However, spindle cells might be reactive fibrosis or like just some reactive connective tissue surrounding the mass, you know? So that's exactly what it is. But you have to look at all the areas and then see which keywords you can grab and then reach the most likely diagnosis. Like looking at this area.
At low power, when I looked at the whole thing, I was actually thinking pleomorphic adenoma with this kind of myxoid, and then
yes,
this is the ductular structure.
Yeah, I kinda heard it in your description. Like, well, I see an area here which has like some spindles. It's not in the surrounding of the tumor. It's right there in the middle. Well, possibly, yeah. But when you look in these,
it's not really
like cystic areas, it would disqualify it a little bit from pleomorphic adenoma. So you start looking again and look for some other keywords.
Is this the X pleomorphic adenoma? Because there are
because you're having like some kind, but we already we didn't even agree that there is pleomorphic adenoma component here.
Okay.
So we didn't even agree that there is a pleomorphic adenoma component here. But I will make it a little bit easier for you. Can you see this this cell? What do you think of what do you think of this cell?
The very large, kind of foamy.
Large, foamy, with the nucleus pushed to the side, right?
Yeah.
With the nucleus pushed to the side. So that's what. Muhammad, if you want to jump in, you can. You can just unmute and jump in.
I think this is kind of a mucus cell push,
Mucus
and then
cell.
it's pushing.
Okay. Yeah, mucus cell. What about this cell? Or these cells? Does they look mucus? They do not. They do not look mucus. They look epithelial. They look epithelial cells. And then you have lakes, big, huge lakes of secretions. Big, huge lakes of secretions, which are highly likely mucus, actually, I think. I think these are lakes of mucus, which is because it's related to these mucus cells. Like, see, the cell is repeating itself. Here's another mucus cell. So it's related to these mucus cells. So I would believe that these are kind of pools of mucin, maybe. So
this is mucoepidermoid carcinoma.
Do you think it is mucoepidermoid? Because I have also Noor is saying secretory. Well, secretory didn't have mucus cells.
And with this kind
Let's
of
throw some
like
stains.
What?
it's
I'm
very
saying this.
mucinous.
Yes, Mohammed. Dina, Mohammed, Dina.
Areas.
Yeah. So what do you think? What were you saying?
Someone wants stains, and I was thinking, like, can we look around just to see more?
Let's look around. Okay, sure, absolutely. So when we look around, you'll see that it's repeating itself, you know? See? The cells are repeating itself, I think. Yes. Here, especially on the border with these like secretions, you have a lot of cells with mucin, intracytoplasmic mucin. Here's another one, very classic. See this cell with pushed nucleus to the periphery here? So that's mucoepidermoid.
But I have a question. If it's mucoepidermoid, shouldn't we see a part that looks squamous?
There is a part that looks squamous. The epithelial cells. These red cells. See these?
In between the mucinous cells, okay.
Yeah, see these red looking cells, which doesn't have mucin in its cytoplasm here. These are actually the squamoid component or the epithelial component. So that's mucoepidermoid. And I would say this is highly likely that it's a high-grade mucoepidermoid. I believe we're seeing these spindle components and seeing this high quantity of like we see the mucin cells like accidentally here and there. And so I believe this is going to be a high-grade mucoepidermoid. But let's look at the microscopic features then. So she's saying these squamoid nests. So that's squamoid nests she's pointing to. These are the squamous cells. And then mucus cells. So here, this is one of the mucus cells. You remember this, Dina? We pointed to one of these cells. And then you have intermediate cells. She didn't even point to intermediate cells because it's not easy to find. And still you see the cystic spaces. Occasionally these cystic spaces, they say they have like papillary projections, and the mucin is often present. See, I told you that these cysts, I believe they are cysts of mucin. See, there may be necrosis. See, there is necrosis here. And atypical mitotic figure or invasion. So this means that we are dealing, I think, with a high grade, as I mentioned. I think it's going to be a high grade mucoepidermoid, I believe. But this is mucoepidermoid. That's what it is. So This is how virtual slides look like. Virtual slides are very tough experience. And actually, this is the one that I'm worrying about more in my board exam. I'm not worrying about the pictures. I'm worrying more about the virtual slides. I hope that they give like clear-cut cases. They won't try to trick us or just like giving me a case that needs careful examination because it won't have time for this, you know?
Yeah,
So,
I have a question. So
yes.
the myxoid area, so this is, as you said, this is just reactive, right? Like we shouldn't be worried about this area, right?
Which one?
The area that looks kind of myxoid with kind of spindle.
Yeah, I believe so. I believe this is just an area maybe of degeneration or something, or even reactive. Like this is reactive fibrosis. Okay, that's the surrounding of the tumor. But I know which one you are talking about. You are talking about this area, right?
I'm not seeing the screen.
Oh, you're not. Oh, sorry. I closed the share screen. I'm sorry. Yeah, that's my fault. Here, you're talking about this
Yes, this
area, right?
area.
Yeah, this area. I know, but I won't have an explanation for this. Possibly this is gonna be like degeneration or fibrosis or some kind of thing in between. But I think there is some mucin here in between. I believe so, but I don't know. And she didn't even comment about it. See, I think if mucin is present extracellularly, maybe that's what she's referring to. Expect associated inflammatory response. So maybe that's like chronic inflammation and fibrosis in response to extracellular mucin. That's what she's pointing on. Maybe, I don't know. This is very, very like a typical feature for a mucoepidermoid, for me at least, based on my narrow experience.
That's a cool case. Thank you.
So the next one is, who's next in line? It's Mariam. Okay, Mariam,
Yes, yeah.
you're lucky. Lucky there's an easy case on the line here. Oh my God, very lucky. Oh yeah. Okay. Very lucky. You know why? Because sometimes we have a virtual slide, but it's not actually a virtual slide. They are spotting on a picture. So very spot diagnosis based. I will show you the picture. I think Abdurrahman would say that's very unfair.
Okay, yeah, I think it's a clear cell.
Yeah, see, that's very like, oh my God, that's a tough case, Abdurrahman, you know?
Yeah.
That's a
Oh,
very
really?
tough case.
Yeah,
Yeah.
it's too easy. It's too easy that it's tough. You know, if you ask somebody what do you see, you can see, oh, I see some clearing there.
Yeah, some clear cells, so that's clear cell. Okay, so that's a very easy case. You're lucky. All right, so let me move on to yes. Okay, let's do this. Okay, so who's next? Next is Muhammad. Muhammad.
Ready?
Okay. So there.
Oh boy.
Oh my goodness. Yeah, it's even the slide I think is even marked. So okay, so low power. Do you think this is basaloid or clear cell or like spindle, or what do you think?
Basaloid, very dark blue to me. Or it could be like actinic.
Could be actinic, but for actinic
Yeah.
cell carcinoma, we need to go very high power and look for
Yeah, for sure.
Do you have any granules here, do you think?
I'm trying to look in detail, but I don't think so.
I don't think so. Yeah, I agree. That's but what's the most prominent feature you're seeing here?
Is this bluish material filling
Yes,
these
bluish.
cavities?
Bluish material.
Yeah.
You're lucky that you're seeing this bluish material.
Yeah.
So
Yeah.
bluish
Starts
material.
with it. Starts with another A. Adenocystic.
Yeah,
I
adenoid
think.
cystic. That's adenoid
Yeah.
cystic
Mhm.
carcinoma.
Uh-huh.
All right, so that's adenoid cystic
Cystic
carcinoma.
carcinoma.
See the case info here? Yes,
I,
it's adenoid
I'm
cystic.
trying to find the perineural invasion because it's so common, but I can't find it now.
We
with
will
this.
see. So see, she's saying epithelial cells. Well, okay, yeah, we know that this is epithelial cells, and then we have myoepithelial cells as well, which is these flat cells you see here. It is compact nucleus, and also we have there is intraluminal, the pseudocysts with intraluminal basophilic matrix, and also some kind of basement membrane like material, which look like I think more of a pinkish in some areas. See here, it's like focal pinkish areas inside this basement membrane, red basement membrane like material intermixed with this basophilic matrix. So what's the molecular for adenoid cystic?
MIB1, something like that.
It's MYB. Good job. MYB1. See, here's molecular
Mm-hmm.
description. It's MYB. And you even have the immunoprofile here. It's very good. This path presenter is very good. It's a very good resource of virtual slides, I think. It's so.
I have a question for Path Presenter, because every time I use it, I don't see the clinical history. I don't see the stains or diagnosis. It's just empty. I just have
Yeah,
the
that's
slide.
because these virtual slides are actually the ones that I'm showing you is coming from this book, the ACE the boards. You know the ACE the boards.
Yeah.
ACE the boards. They have some QR codes with some path presenter slides in which they put all the educational details. It's very good in breasts and very good also in salivary glands. That's why I'm showing you virtual slides here, because it's much better than looking at pictures, you know. So who's the lucky next one in the line? He is Noor.
Alia.
Alia.
Noor.
Oh, Alia, but she's gone. I don't see her anymore. She might be gone. So Noor, what are you there? Yes. So Noor always prefer the chat. He doesn't like yeah, a shy person. Okay, so it's okay. Whatever. It's actually very easy case. But I will ask you the first question first, and then I will wait for your response on the chat. What do you think from low power here? What do you think? This is like basaloid, spindle, oncocytic, clear. Well, okay, that's oncocytic. So going high power here, what do you think? Very easy. Boom, spot diagnosis, oncocytoma. Okay. Oncocytoma versus oncocytic carcinoma. But it all depends on a lot of features and careful examination of the slide. However, I think this is oncocytoma only. Yes, title is oncocytoma. Oncocytoma, you see this nests of oncocytic cells or nests of oncocytes. Okay, oncocytoma. All right. Thank you, Seham. The last one in the line.
I'm here.
All right, good. So I don't know. I can't see it in the book. Interesting. Yes, here. Okay. Okay, okay. That's good. That's a good one. Okay. Let me see it first real quick. I make sure. I don't know. I don't believe this slide is the best. So it's a no. No. So I don't know. I can't find it. So so I will show you another one, but I was trying to get a very specific entity, but I can't find it in the book for some reason. So we'll just hit this entity and that's it. So let me share the screen. That's the very last one.
Okay.
So what do you think here, Sam?
I think it's basaloid.
Basaloid?
Based on,
Okay.
yeah.
Going high
Okay.
power.
Okay. Is that a lymphoid infiltrate?
So that's lymphoid tissue or lymphocyte. Maybe inflammation. I don't know, but you know,
Okay.
let's look around in the cells and see. No, not anything with lymphoid tissue is a worsen. We need to see the double layer. And I can't see any oncocytic cells here with a double layer.
Yeah.
I'm not convinced that this is worsen, but what do you think about the cells? Because I can't go higher power. Unfortunately, let's go 40x maybe, but the quality gets really bad when you go 40x. I don't know.
Which cells?
These, like the whole
Yeah.
cells, these cells. What do you think of the
They look
cytoplasm?
like they have a granular cytoplasm.
Granular cytoplasm. Yes.
No.
What kind of granules are there? What kind of granules do you think?
Zymogen.
Zymogen granules. Yeah, I agree. That's I think that's acinic cell.
Oh, acinic cell.
That's acinic
Okay.
cell carcinoma, and it has some kind of lymphocytic infiltrate here, maybe infiltrating, and that's why it looks very. It looks like the Warthin, but it's not Warthin, of course. See, all the cells have some granules in the cytoplasm there.
Yes.
So that's the case info here, acinic cell carcinoma. And it has this NR4A, the molecular. Remember this?
DOG1.
Yes. So DOG1 SOX10. Yes. DOG1 SOX10. So these are the zymogen granules. She's referring to this one. Yes. These are the granules that we saw everywhere. And it has some kind of eccentric, she's saying eccentric located nuclei, some variable chromatin with zymogen. That's the only keyword that you have is the zymogen granules, which are there in the cells. Okay.
Yes.
All right.
Thank you.
So that's it for today. We'll see you after tomorrow. We'll go over the entities of the other head and neck entities. I hope I can cover them in one lecture. However, I will make sure I include the board relevant entities in one PowerPoint. However, we covered the salivary gland tumors, benign thyroid, malignant thyroid, and these are the key important things in the head and neck. However, I will go on the upper aerodigestive system. We'll go over the sinuses, some mandibular lesions, and also some neck masses, some other neck masses, parathyroid as well we need to cover. So we have a lot of remaining things to cover, but they are just like here and there entities. They are not like a bulk. Thank you very much, and I'll see you after tomorrow. Okay. Enjoy the rest of your day. Thank you.
Thank you.
Thank you, Ta.
Thank you.